So I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z.
I'm your host, Jim Pruitt, aka PharmD and ED, and I'm bringing you another episode of the Pharm So Hard podcast. Today, I have one of the more controversial topics that I've done in a while. And to be honest, the more I look at this data, the more confused I get and the more intrigued I get. But let's get into today's episode talking about Etomidate for RSI in the seizing patient. And shout out to our sister websites. Again, Pharmacy Friday Pearl is going to be great, which a lot of our information and topics come from. Pharmacy and Acute Care University, or PACU, I like to call it, is going to be our premium membership website. And the cool thing is we're going to be adding CE to that within the next few months. We're doing a lot of our premium big time work in our membership over there. So you definitely want to get checked in and just check it out. Again, we have trials in there so you can just see if that's something that you're interested in. If you don't like it, please write me on Twitter, write me wherever, and let me know, hey, this platform sucks and why, and I'll make sure to make it right for you. And lastly, guys, our Empower conference was great last month, and now based off your feedback, we've got home study CE available for you guys, so go check the website out. Again, all this information is going to be in the show notes, so please go check that out. So let's go ahead and jump into this episode. RSI, or rapid sequence intubation, is going to be a process whereby induction agent is going to be followed by a neuromuscular blocking agent given in rapid cessation to facilitate endotracheal intubation. However, the selection of a sedative depends on multiple factors, looking at the clinical scenario, which patient factors are involved, looking from a cardiopulmonary standpoint, neurological status, allergies, comorbidities. All these things are going to help our clinician pick which agent we will use. Etomidate is going to be the most common agent, and we would like to say, in today, again, this is going to be in the end of April 2022, it's the most commonly used agent that I've seen when we surveyed providers and different pharmacists out there. And one of the big things is the fact that it's going to be, from a hemodynamic standpoint, pretty favorable. But there's a few things that we have to consider in certain patient populations, particularly those neurology patients, when you have this myoclonus that's going to be associated with it when you give it. About half of the time, some data saying up to 70% of the time, you have this very strong myoclonic jerk and just tightening. It looks like posturing at times, or it looks like a seizure. And separately, independent from that, is the fact that there's a risk of decreasing the seizure threshold. And this is something that's going to be unique to Etomidate. The more I look into it and pick up some of my anesthesia textbooks, it's going to be very common with some of the agents that we use, like ketamine as well. But again, not as popularized and not talked about to the degree that it is with Etomidate. So when looking at the dosing of Etomidate, it's going to be 0.3 mg per kg, ranging anywhere from 15 to 20 milligrams for most of our patients, and then for our larger patients, up to 30 milligrams. It's going to be given an IV push, and the onset's going to be about 20 seconds, and with a duration of 4 to 10 minutes, you're going to have metabolism by hydrolysis of the ester side, and then you're going to have renal excretion about 75%. Some adverse effects to look for is this injection site pain. You can have some nausea and vomiting associated with it. And then the big thing that comes up is this myoclonus that, for the most part, the data saying is not always again, seizure-like activity on the EEG, but the thing that we're going to talk about the most today is this decrease in seizure threshold, or the production of seizures. From a hemodynamic standpoint, the reason that we love Etomidate is because it's not going to have much on a blood pressure or cardiac output or heart rate standpoint. We know there's some issues with a decrease in cortisol due to inhibition of steroid synthesis, particularly in a critically ill patient population. And there isn't much of a issue when it comes to ICP. There's some data looking at it potentially can decrease ICP and intraocular pressure as well. Contrast that to some of the other agents that we have, like ketamine, that increases blood pressure and heart rate and cardiac output. Not much issues on cortisol, and this theoretical increase with older data, but most of the newer data saying it's going to have no impact or decrease in intracranial pressure. And then looking at propofol, that actually decreases your blood pressure, potentially can have no difference to decrease in heart rate, decrease in cardiac output, no issues with cortisol, and a pretty consistent data looking at it reducing intracranial pressure. So the real question that comes up quite often is whether or not Etomidate causes seizures. And that's something that we all want to know. And I thought it was a very simple question, but the more I looked at this data, guys, the more intriguing that it really got. So I reached out to Twitter and I reached out to Instagram to see, hey, do you guys think etomidate causes seizures in RSI? And most people said no, but 74% of people in this poll said no, and only 26% of people said yeah. And then ask myself the next question, like, what is this myoclonic reaction or this myoclonus that's going to be associated with etomidate? And it is known to happen in 30 to 60% of patients upon administration. And the mechanism is believed to be related to the disinhibition of the extrapyramidal motor activities. And this is similar to like restless legs during sleep and not due to epileptic focus. But this is also controversial depending on the type of seizures. And I'm not going to pretend to be a neurologist. I'm not going to pretend to be someone who understands the depth. But when I look at some of the textbooks, I look at some of the data and I reach out to my friends, they say that it's not very easy to catch certain myoclonic seizures on EEG. So again, most of them is not, but at the same time, we can't say for 100% certainty that all of these patients are not having any type of seizures when it comes to that myoclonic reaction that happens upon injection. So the next thing that comes up is that the theory of if etomidate promotes seizures, which patient population is at risk? And I reached out to people out on social media, and of course they would say those people who are already seizing, and I had to go and see what does the anesthesia textbook say, because that's going to be something that I think is unique as well. And I really want to emphasize what this particular textbook said. It's Miller's Anesthesia, the 9th edition. It said that etomidate has been shown to precipitate generalized epileptic EEG activity in epileptic patients, and its use in this population probably should be avoided. However, it is electively used in low doses to activate seizure foci for the purpose of intraoperative EEG localization. And the other component of that is that the preceding information, notwithstanding no convincing reports, indicate that epileptogenesis in subjects who are neurologically normal and the use of etomidate need not be restricted on the basis. In fact, etomidate has been used to control refractory status epilepticus. So to be honest, guys, when I read that, it really just threw me all over the place, because if we're going to use something that can be used in surgery to activate seizure foci, that's pretty troubling for me in a patient, and to promote that there's some data saying that you can cause some generalized seizing in patients with an EEG, that's concerning as well. And I want to figure out, okay, if this is the case, and I've had some interactions with our anesthesia colleagues and asked the same question, I was like, what is the actual clinical data, particularly in those patients and for the people who were intubating in the ED? So let's move forward, talk about the data. I want to go all the way back to one of the first studies that I was able to find in textbooks and things of that nature in 1977. This was a clinical and electroencephalographic comparison with thiopentol. Again, etomidate versus thiopentol. This was done by Dr. Cronin and colleagues in Iowa City, Iowa. So a little background, this is a study looking at 120 elective surgery patients receiving either etomidate or thiopentol for anesthesia induction. And what they found was that there's myoclonic movements in 28% of those patients that got etomidate compared to 0% of those that got sodium thiopentol. These tonic movements, again, which they characterize a little differently, happen in 11% of patients with etomidate compared to 1% in thiopentol. But the interesting part was that they noted no epileptiform discharges were noted in 10 patients who had EEG monitoring. Again, not necessarily something that is very, reassuring, especially at that initial time, to let us know, hey, is these myoclonic movements, purposeful, or are these things something that's causing EEG, or are we missing it in some of these patients? So I was intrigued by that and wanted to look a little deeper and look into more information. So this is another one that I saw in the textbooks. Again, I like to always go and double check behind these textbooks to see. And this study was done by Ibrahim and colleagues, and it was titled The Effects of Etomidate on EEG of Patients with Epilepsy. So I thought that was a cool one, and this was actually published in 1986. And what they did was look at patients, it was 12 patients rather, with intractable seizures undergoing cortical reception of seizure foci, receiving etomidate for anesthesia. So all these patients got Etomidate. 9 out of 12 had an increase in epileptic form activity after Etomidate administration. And I thought that was rather intriguing, to be honest. And they have some graphics here. They looked at the type of waves for each of these patients. So that gave me a little bit to be concerned with again. But looking at the type of study and the strength of this, again, we're looking at just 12 patients that's already seasoned that we're going in and doing surgery on, over 30 years ago. I'm not too strong with this data, but it's at least something that make me consider. There was another study that was done by Dr. Gaber and colleagues. This is what I saw the most of when I start pulling articles on PubMed. It's the comparison of Etomidate with other agents on the impact of seizure thresholds during ECT therapy. And that was pretty interesting. And then the patient population was going to be those with schizophrenia. This one was done in 2007. And what they did was they compared 30 patients. Again, this randomized crossover study. So those who got propofol got 1 mg per kg, and those who got Etomidate got 0.2 mg per kg, which is, again, slightly less than what we use. And after Etomidate induction, seizure durations registered either by EEG or EMG were longer than propofol treated cases. However, there was no significant differences found for the minimum seizure eliciting stimulating energy or the number of restimulations between the two anesthetics. So again, that was intriguing because it doesn't necessarily let me know about the seizure threshold, because I thought that it would take more or less energy to actually stimulate a seizure in these patients. So that was intriguing, but the fact that it actually had a longer seizure also was another thing that made me a little bit more concerned. So I saw those older data, I saw an ECT, I saw that, and I was just wondering, is there anything out there in the ED? We're looking at seizures, looking at anything, because it made me a little concerned, because again, I know places that I've been and people I've talked to, we give a significant amount of Etomidate, and I want to figure out, is there anything else in the ED? So this study was done by Goldner and colleagues, and what they did was look at their Etomidate use across the board in intubating children. They wanted to see the hemodynamic effect and the adverse effects. And what they did was look at 105 pediatric patients undergoing RSI, and they found that no patients had seizures in the ED. However, there was 4 patients with a known seizure history that had seizures after hospital admission. So at some point during their hospitalization, they had a seizure. But again, I can't put that all on Etomidate, but I am intrigued, to be honest. So something that I want to see more of. This next one was done by Perrier and colleagues, and this was the Icto study group. And this was a really intriguing one for me. This one was a comparison of Etomidate and sodium thiopental for induction during RSI and convulsive status epilepticus patients. This was something I raised my eyebrows. This was done in 2018. And let's be honest, I was heavily intrigued. This was done in a unit in France. So they looked at 97 patients undergoing RSI with Etomidate or thiopental, again, in the ED or ICU for convulsive status. And what they found was that seizures or status epilepticus reoccurred in 56 patients in the Etomidate group compared to 44% of patients in the sodium thiopental group. They didn't report it being statistically significant, but again, it's something to consider. The two groups, again, were not significantly different for the proportion of patients with hemodynamic instability after intubation or those with difficult intubation. So again, it made it to where there's almost nothing that was different across the board. But a few things that come up in my head as I continue to read this is, man, if they had, 1,000 patients, would that have been different? And I don't know. I really don't know. And it's just something that intrigued me. Again, what was coming at me is saying that there's something we should look at. But again, this data, again, in the pediatric population and looking at this one here, it's not anything that is actually saying from a scientific standpoint that Etomidate is causing more seizures. And I also want to look at this and figure out if there's any other studies that support, or using Etomidate and seizures. And we looked at this additional study done in a general population. And again, they found that there was no relationship between seizures after Etomidate administration and a prior history. So again, there was no association in that group there. Of course, Etomidate did a great job for intubating conditions, and there was a slight decrease in blood pressure, and the corticosteroids was actually giving in a decent amount of their patients for varying reasons. But again, overall, the big thing I want to get out of this study was figuring out whether or not there's a relationship between seizures and people that had a prior history. So I'm perplexed, guys. I'm not gonna lie. Again, I know that Etomidate is gonna be commonly used in a significant amount of emergency settings, and that Etomidate has been shown to elicit myoclonus in a significant amount of patients. The issue that I have is that is this myoclonus what people are calling seizures? Is whether this myoclonus is actually confirmed epileptiform activity? That seems to be unknown, especially after talking to people who's much smarter than me. And to make, again, as I said before, depending on the origin and the type of seizure, it may be challenging for EEG to differentiate between non-seizure and seizure activity during myoclonic events. So something to consider, and it gives me a lot of uncertainty. But the way I look at it is due to this low level of evidence and due to just a lot of uncertainty in patients with a history of seizure, there should be a risk versus benefit assessment to figure out what's the best agent. We have propofol that we know have anti-seizure properties. We have ketamine that we know have anti-seizure properties, particularly at the dosing that we use. And I'm perplexed when it comes to this. And I want to hear you guys' thoughts. If you're anesthesia, your ED, all that, and you just think I'm a complete idiot, that's completely fine. I am so uncertain on this, and it's something that I want to learn more on, and it's something that I want to hear if there's more data out there, because it just seems like a lot of things are uncertain, and I'm unable to make any strong recommendations one way or the other. It just looks like it could, but the data is not saying that exactly across the board. So again, appreciate you guys. This has been really great. And I'm just intrigued with this topic, and I want to hear more from you guys. So go check a lot of this stuff out. The PowerPoint that I made for this, the Pearl that's been sent there, all that's going to be in the show notes. So go check that out for certain. And just let me know how you feel. Send this episode to some of your anesthesia friends, your neurology friends, and have them say, hey, Jimmy's an idiot. This definitely happens. Here's some studies that he didn't look at in the general population, and this is why you should or should not use it. But I'm intrigued for sure. Definitely appreciate you guys for listening to another episode of Pharm So Hard. Again, continue to check this stuff out. Let me know on social media, email, all the things that you like, the stuff you don't like, and we can really go from there. Please, like, rank us, subscribe to our podcast on all the major platforms, Apple Podcasts, Spotify, Google Podcasts, all those things. So just let us know what you enjoy. And again, I'm going to end it the same way in every episode. You don't have to be a pharmacist. You don't have to work in the ED, but everything you do, make sure you pharm so hard.
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't there.
Perfect.